Good evening, everyone. Welcome to our Ethics in Society public lecture, our second online program. Thank you all so much for taking the time to join us here tonight. 2 months ago, during our first COVID-19 public ethics lecture, we had our largest turnout ever, until of course tonight, when we beat even that previous record. So on behalf of the entire Community Memorial Health System, thanks to each of you for tuning in and being an important part of our community's effort to study together, learn together, and continue the Ventura tradition of collaboration, collegiality, and kindness. My name is Dr. Jim Hornstein. I am the chairman of the Community Memorial Health Systems Bioethics Committee, and it is my absolute pleasure to moderate tonight's incredibly timely and provocative program entitled, Should You Trust Vaccines? Now, there are only 4 small words in this title, Should You Trust Vaccines? And by way of introduction, let me explain to you why I picked each of those 4 words. First, let me start with the word should. Whenever you hear the word should, it's reasonable to think that you might be dealing with an ethics question. Let me give you some examples. Should I steal a car? Probably not. Should I take a flu shot? You probably should. Should I wear a mask in public? You absolutely should. All of these should questions really are asking, is some action I'm about to take right or wrong, good or bad? And that's exactly why we're here tonight, to try to help all of us make the right and the good and the best decisions about vaccines for ourselves, our community, our friends, and our loved ones. Now, returning back to our tonight's title, Should You Trust Vaccines? Let me speak for a moment about vaccines. Last week, public health officials announced throughout the United States that one, if not more, COVID-19 vaccines might be available as soon as next month, and next month is December. Also, last week, Pfizer Pharmaceuticals reported that early data suggests that its vaccine is 90% effective. 2 days ago, Moderna beat them and reported that their vaccine was 94.5% effective. And just this morning, Pfizer again spoke about its COVID-19 vaccine, stating final results showed that it was 95% effective with no serious side effects. Now that's absolutely amazing news. So much so that Dr. Anthony Fauci, the nation's top infectious disease specialist, announced on Good Morning America that, quote, the cavalry is finally coming, unquote, and that vaccine shot should be available to all Americans around April. But before we start celebrating, let's actually pause for a second and ask ourselves some basic questions. How exactly do vaccines work? Do they really prevent the disease we want them to prevent? Are they safe for everyone to take, or can they in and of themselves cause their own diseases? These are exactly the questions our first expert speaker will answer in her talk to us about the science of prevention. Now let's return again to our title, Should You Trust Vaccines? And let's look at the third word, and that is to highlight the word trust. Now, none of us, I'm pretty sure, needs to be convinced that as a country, we have a serious crisis of trust. Numerous studies have shown that trust in almost every societal institution, the government, political parties, the media, business, the stock market, healthcare, churches, even the Boy Scouts, is lower than it was only 10 years ago. And it is significantly lower than it was a generation ago. And in many cases, trust may be at historical lows. But you might ask, so what? Who cares if we live in a low trust environment? And the answer is we should all care, and we should all care deeply. As Stephen Covey taught us, when you trust people, you have confidence in them, in their integrity, and in their abilities. But when you distrust people, you are suspicious of them, of their integrity, of their agenda, of their capabilities, and of their track record. And once we don't trust someone, the consequences are not just small, they're dramatic. And in the case of a COVID-19 pandemic, they're potentially deadly. And that's what our second expert scholar will speak to us about tonight. That even if we have the best and most compelling science, 90 to 95% effectiveness, still some of our fellow Americans may still not trust vaccines or the institutions which produce them or that license them. And since we are all in this pandemic together, what should we now do? Is it possible as a community to try to rebuild trust between skeptical, angry, and frankly, COVID-19 exhausted neighbors? Which leads me to the final and perhaps most important word in tonight's topic. Should you trust vaccines? And that word is you. The entire point of tonight's discussion is to inform, engage, and frankly, listen to you, the entire Ventura community. What do you want to know about vaccines? What are you most worried about? With vaccine delivery literally only a few weeks away, what questions do you have that really need to be answered tonight? Because we want tonight's seminar to be interactive, during all of these presentations, please use your chat box to ask any questions you may have. During our Q&A session, I will try to field as many questions as I can and present them in real time to our experts. I assure you, there are no such thing as silly questions. Whatever you are wondering about, I guarantee you that 10 other people are wondering the same thing. And I absolutely hope, and I absolutely believe that by the end of tonight's program, together, all of us will come up with some really good answers to the question of the evening: should you and should all of us trust vaccines? And frankly, we're going to need those answers sooner than later. Now, before I introduce tonight's speakers, let me acknowledge the generous sponsors for tonight's program. First, I'd like to thank the administration, the Board of Trustees, the doctors, the nurses, and all the staff at the Community Memorial Health System. In this unprecedented year of COVID-19, I think we all should thank not just CMHS for helping tonight's program come to fruition, but also for their incredible dedication, their incredible professionalism, and their tireless commitment to the care and to the well-being of our entire Ventura community. I'd also like to thank the Community Memorial Healthcare Foundation, the philanthropic arm of our health system, which generously supports our ongoing commitments to excellence and to caring. I'd like to single out a few people who were instrumental in tonight's program: Mrs. Lydia Hops, the dedicated president of the Community Memorial Healthcare Foundation, Megan O'Neill, Tracy Shoup, and the entire marketing and development staff, Lindsay Stetson and Evelyn Scott, all their ongoing technical support and their help. And frankly, a special acknowledgement to Mike Ellingson, a senior vice president at the Community Memorial Health System. Mike and I started this Ethics and Society lecture series over 8 years ago. And it is without a doubt that his support, his humor, and his tolerance of our programs would literally never have allowed us to continue for 8 years or to be here tonight. Mike is retiring soon, and I hope one of many legacies of his successful tenure here will be that he has put ethics and integrity front and center in all of the programming in our institution and throughout our community. Thanks so much, Mike, and best of luck to you in your future endeavors. And finally, a quick shout out to my beautiful wife, Dana, for just about everything else which has been good in my life. And now it's my great pleasure to introduce tonight's keynote speakers. The first speaker is Dr. Diane Birnbaumer, Emeritus Professor of Medicine at the David Geffen School of Medicine at UCLA. Dr. Birnbaumer was born and raised in Thousand Oaks, California. She attended the University of California, Irvine, where she received an undergraduate degree in biology. She received her medical degree from George Washington Medical School in Washington, D.C. She completed her residency in internal medicine from the University of California at San Francisco, and then another residency in emergency medicine from Harbor UCLA in Torrance. In addition to being a professor of medicine, she is also a senior clinical educator at the Harbor UCLA Medical Center. An interesting fact about Diane, which I learned recently, is at the age of 16, while living in Thousand Oaks, a high school counselor of hers recommended she spend the summer in Ventura at the Ventura County Medical Center as a summer student scholar. Having never spent significant time with doctors or in a hospital before, Dr. Birnbaumer says that summer in Ventura literally changed her career and her life. So ladies and gentlemen, it's my great honor to welcome back to Ventura, one of our own, Dr. Diane Birnbaumer.
Hi, everybody. I'm going to share my screen. And I have to thank, first of all, I have to thank Dr. Hornstein for calling me about this. This has been really exciting and fun to develop this and think about sort of bringing this information to the public. I lecture all the time to other medical people, but it's wonderful to talk to the public. I really wish I were there talking to you real time in person, but we're being safe. And this virtual platform gives us the opportunity to bring this to as many people as want to sign in. So I hope you're going to end this evening with some information and get your questions answered and a little bit of history. I think it's really important to kind of know where we came from. So yes, I'm an emeritus professor and I'm a senior whatever educator, which makes me feel like I should be about 100 years old. I'm not. I'm knocking on the door, but I'm not quite 100 years old yet. And I want to talk about this whole idea of vaccines. We're going to spend over an hour together talking about vaccines, which brings us to this whole idea of infectious diseases. So the whole reason vaccines exist is because we as humans, or any creature on this planet basically, infectious diseases are a really big problem. And the majority of infectious diseases, the lion's share of infectious diseases, are caused by bacteria and viruses. Now there's some fungi out there and some other kind of organisms, but the reality is the vast majority of little micro things that come at us are bacteria and viruses. But they are two distinctly different things, bacteria and viruses. So bacteria are actually self-contained cellular organisms, and they're complicated. They have a cell wall and they have little machinery inside that makes it work. And bacteria, as long as they have a substrate, they have whatever they want to grow on, they can live by themselves. So if you happen to have potato salad, or better yet, let's take your turkey on Thursday, and you don't cook it quite enough, it's going to be a great sort of substrate for that bacteria to be growing around in there. We know bacteria grow and they're on their own. They don't need us. They can grow just fine as long as they have a substrate. That's different from a virus. A virus is kind of a mean, lean infection machine that needs you. It hijacks your cells. It can't really live very well by itself. It hijacks your cells. That's how it infects you. So it actually has less kind of areas for us to try to attack it. So if you look at that bacteria on this slide, there's lots of levels we can attack this with an antibiotic. We can go in there and break up the cell wall. We can go in and mess up the machinery inside. We can do lots of things to a bacteria. So we have lots of antibiotics. But that lean, mean infection machine, that virus that has to hijack your cells to live, there aren't a lot of treatments we have, antiviral treatments we have that work for you. So think about the gajillion colds you've had in your life. And your medical person may have said to you, oh, well, you know, I can treat the symptoms, but you're just going to have to ride it out. That's because we don't have a lot of antivirals. So when it comes to viruses, we just don't have a lot of magic pills. There's just not a lot out there we can do. So what that means is if we don't have treatment for something, what we'd really prefer to do is prevent it. We'd prefer to not have you get infected at all. So what I want to do is I'm going to take us back. We're going to go back in time a little bit here. I want to go back into some time travel. We're going to basically go back to the future. And I want to go back to before we had vaccines. I want to go to a world where, and I'd love to ask all of you out there, how many of you have had some of the diseases we're going to talk about, or knew someone who had some of the diseases we're going to talk about. But the life before vaccines was a very different thing than what we're used to now. And one of the ways, when I travel, I love to travel, at least I used to back when I used to be able to. And one of the things that I used to do when I traveled is I would go to cities. And one of the things I'd like to do was go, maybe it's a weird thing, but I would go to cemeteries. And one of the reasons I would go to cemeteries is I found that there's a lot of sort of anthropologic information you can get. It's like an anthropologic flash of time that you can see about what kinds of infections happened then, what wartime did, what religions were there. You'd learn a lot from cemeteries. And I recently was reading articles about what life was like before vaccines. I was reading an article about the 20s to the 1960s, 1950s, and it was in a little town back east. And one of the pictures in that article was this, and I found it very moving. So here is a cemetery where in 1895, 10-year-old Joyce died of polio, and 10-year-old Colin in 1945 died of tetanus. And then we had influenza meningitis kill 4-year-old Lynette in 1946, and poor Wallace James. In 1920, at the age of 2, he died of both measles and diphtheria. We have vaccines for every single thing that those kids died of. And back in the day, when these diseases were ravaging and they were just everywhere and there was nothing we could do, things like this would happen. So here's a headstone where in 1903, a single family in 4 days lost 5 children from the ages of 2 to 15. This was probably yellow fever, which is another thing we have a vaccine for, another virus that we have a vaccine for. This was not uncommon. So if you stroll through cemeteries in Europe or back east or down in New Orleans, you're going to find headstones or areas of headstones where people died by, a lot of people died from these outbreaks of things we just couldn't treat. In fact, there was a saying in the late 19th century, you're not really a mother until you've lost a child. And I think if you go back even in your own family history for the last couple of generations, you will find that a couple of generations ago, you had aunts and uncles or great aunts and great uncles who died or who had siblings who died of these infections. So what were these infections? What did people get? Well, there's a lot of things that ravaged the world before we had vaccines. One of the big ones that we fortunately haven't had too much in our lifetimes was smallpox. So smallpox is devastating. It completely wiped out entire communities, smallpox, for centuries. And smallpox is basically an infectious disease that kills 30% of people who get it. And if you survive, this poor baby on the left side of your picture here, this child with all this, those are going to crust over, and all of those things are going to scar. And people would go blind and they would have permanent scarring. And here's this is from a photograph that's been colorized, but all of these lesions are going to scar. And this has been something through history, the scars of smallpox. If you liked the movie Mary Queen of Scots that Margot Robbie starred in, she gets smallpox. And Elizabeth I got smallpox and ended up so disfigured. She's kind of renowned for the thick makeup that she used to wear to try to hide the scars of smallpox. So we have vaccines for that. Measles. So measles is a wily little devil. It's a tiny, tiny, tiny virus that lasts in air in a room for up to 24 hours, just floating around in the air. And if you're not immune to measles, you have a 90% chance of getting it if you're exposed to somebody who has it. It's highly infectious, and it causes pneumonias, and it causes brain inflammation, and it causes women who are pregnant to go into preterm labor if they get it. Measles, again, was rampant for a long time. Mumps. So mumps, you used to have to quarantine at home if you got the mumps. Greg can't come out and play because he has mumps. And mumps causes pneumonia in kids, and ear infections, and brain inflammation, and swelling of the testicles in little boys. And so mumps was something that kids got locked up with. And I stayed at home with. And then this. So this was profound. And many of you, I'm sure, recognize what those things are. But in this picture, those are iron lungs. Those are ventilators. They're ventilators that work by basically, it's negative pressure. It runs not a tube down, but this helps you breathe by just being in this thing where pressure changes inside this chamber. And each and every one of these, there's a person inside. There were rooms and whole wards of people with this. Where basically, and look at this is polio, by the way. And they try to make this happy. Here's people with balloons on their iron lung machines, and they have to have mirrors so that they can actually see and talk to people, because this is the only way they could breathe. There's little tiny ones in here of little kids that are in these things. This is polio. Polio infected a lot of kids in the 1950s, in particular, from the 20s on to the 50s, and 5 to 15% died, and 60% ended up with some sort of paralysis. I have a friend who has a withered leg and a splint that he wears, a little thing that he wears, because he had polio as a kid. Mortality rates are high, really bad morbidity with this thing. And it led to things like this. There sometimes weren't enough iron lungs to go around, so they would create one gigantic one and basically just slot people into this thing. They would put signs outside of people's houses that would say, "You'll keep off this street, there's infantile paralysis." And think about what happened in New York in May with COVID. It's the same thing. They ran away from COVID because this is a headline saying New Yorkers fleeing New York because of infantile paralysis. There were things that if you would drive through neighborhood or through cities where they would have polio, you couldn't stop. They would say, "Keep going, we have polio here." And they did public health measures. So look at this. This is a poster. It basically says you can't have a 4th of July party that was forbidden by the police. Children under 16 weren't allowed to go to the movies because of a risk of them getting polio. These are public health measures, and it's very sort of echoing of what we're hearing these days. And things like this: don't mix in groups, keep yourself clean. These are things that they would do to try to prevent polio, because polio was devastating. It did lead to the fact that basically what was the March of Dimes, it was called the National Foundation for Infantile Paralysis, that not surprisingly was started by FDR. FDR in 1921 got polio and he was an adult who got polio and ended up not being able to walk. That's why he was in a wheelchair. So, for all of the pictures we see of him, he got polio and he started this. So that's kind of the history of what happened. It was really profound. These infections were devastating. So how did we end up with this vaccine stuff? How did this all, like timeline-wise, how did it start? Well, actually, in the year 1000 in China, they started trying to use vaccines. But the thing that we know the most about is Edward Jenner's famous experiment, where in 1798, there was smallpox, that thing that causes all those terrible lesions and scars, et cetera, and kills people. Smallpox was pretty ravaging. And what he did is he took a pox from a cow that was sort of like smallpox, took the scab off of that, and kind of rubbed it into a wound on a human, just to see what would happen. Would that prevent that human from getting smallpox? And lo and behold, there was an effect. Now, it took a while to perfect a vaccine from that, but that was a brilliant idea, absolutely brilliant. Polio, I mentioned, was causing 60,000 cases a year in the United States in 1952. A vaccine would be great, and they did. They started to develop this polio vaccine. That's the first one that was by Salk. The oral one took a little while to develop, but that was a few years later, but that's in the 1950s and 60s. A measles vaccine happened. Remember, measles, so infectious, causes inflammation of your brain. Measles vaccine happened. We ended up eradicating smallpox in the world in 1980. Smallpox was gone because of vaccines. Measles and rubella in the United States were no longer considered endemic in the early 2000s. So pregnant women, where something like rubella, which was the German measles, would cause deformities in the fetus, or the measles would cause the woman to go to preterm labor, it just didn't happen anymore. We basically had gotten this thing under control. Pretty dramatic stuff, saving lives, causing huge benefit. And then let's go back to the pandemic that's before this one. The Spanish flu killed 50 million people nationwide in 1918 and 1919. Devastating. It killed 650,000 people in this country. So we're knocking on that door with the rate we're going. I hope we don't ever get there. And we ended up with a vaccine for influenza. It was wonderful, except it took 27 years. So the worry here when COVID came is, was it going to take 27 years for us to get a vaccine? Could we have such a gigantic pandemic and wait 27 years for a vaccine? We'll come back to the good news about that in the second part of this. So when these vaccines got out there, what happened to measles? So in 1971, they had the MMR, measles, mumps, rubella vaccine, and they had a big push in 1978 to get it out there, and it went away. Measles basically almost disappeared in the United States. It was beautiful. And internationally, the oral polio vaccine, there was a World Health Organization international push where they took these oral drops out into the middle of nowhere across all the world, and they were able to almost eradicate polio. And in fact, to the point where there are only 2 places in the world that still have had cases of polio, dribs and drabs here and there, but the vast majority of polio has been eradicated in the world. That is incredible. Smallpox is considered gone. Smallpox was declared dead in 1980. So I mean, there was tremendous progress. We went from literally everyone knowing someone who had or was, devastated by a problem, has may die from these, and we had it gone. So how great? What could possibly go wrong? Well, actually, several things could possibly go wrong. These are children with measles. All of these children have measles. I've seen a few measles cases because we've had a few outbreaks, but I will tell you who haven't seen measles cases are multiple generations now of medical students and healthcare providers who, when they've gone through school, they learned about it in school, but have never really seen it, don't know how to recognize it, have no idea how to treat it. They don't see it anymore. They don't know. And at the same time as these there aren't a lot of cases around anymore, people don't really know how to recognize them anymore, has been a parallel issue that's come up, which is the pushback to mandatory vaccines. And that has led to less vaccination than we've had in the past. So what's the shakeout of that? What's the shakeout of this? Well, mumps is one of them. In 2016, Harvard and Yale had an outbreak of mumps. So did multiple other colleges in this country. In 2019, just last year, which seems like a century ago, doesn't it? But just last year, there were outbreaks in Temple. These university outbreaks happen because some of the kids are getting there. They're not vaccinated. They're all smushed together in there. And it turns out that this population gets mumps. So we've seen outbreaks of mumps mainly in university populations because of vaccines that aren't happening in the kids. And even just January of this year, they were tracking the problem with the mumps outbreaks because the kids were all in college together. Now that is not a problem anymore because nobody's together right now, but that was what was happening. And these outbreaks of diseases we thought were kind of gone even happen in places like the happiest place on earth. So in 2015, there was an outbreak in Southern California that started in Disneyland. It started because a European tourist went to Disneyland, was unvaccinated, had measles. And remember, measles hangs in the air for 24 hours. And if you're not immune to it and you get exposed, you have a 90% chance of picking this thing up. It led to a localized outbreak. And in fact, this was when we started seeing at the hospital where I work. So down here at Harbor General, we saw a couple of Harbor UCLA, we saw cases of measles that happened. So it led to these now outbreaks we're seeing of measles because of vaccination, sort of people that don't necessarily vaccinate. And we're going to hear more about that in a second. So if you kind of put it all together, we went through these terrible times of terrible diseases that we couldn't treat. And then we figured out a way to fix it, to get vaccines out there. And now we're kind of in a place where there's some vaccine pushback and some of these diseases are coming back. And this kind of thing that the CDC put out was something we had to learn about because we were seeing things again. And then the one thing that's kind of posed on the horizon right now that's a little concerning is COVID has had a big impact on vaccination. So a lot of kids have missed these booster shots that they would need, or the normal vaccination schedule they would need. And just in the paper today was an article about the concern for measles. And are we going to be seeing measles in the beginning of 2021? With these kids not being immune and with it being very infectious, even if there's just one case around, are we going to see this more? So I'm going to turn this over to my colleague. I'm going to stop sharing my screen. I'm going to come back and give you more of the science part of this in a little while, but I'm going to stop sharing my screen here and pass this off so you can hear more about these vaccines themselves.
Thank you so much, Diane. That was excellent. Our second expert speaker is Dr. Monica Schock-Spana. Dr. Schock-Spana was born and raised in San Antonio, Texas. As an undergraduate, she attended Bryn Mawr College outside Philadelphia, where she graduated with a degree in cultural anthropology. She completed her graduate work at the Johns Hopkins University near Baltimore, where she graduated with a PhD in anthropology. She is currently a senior scientist at one of our country's premier public health schools, the Johns Hopkins Bloomberg School of Public Health, working at the Center for Health Security. In her spare time, Dr. Schock-Spana enjoys gardening, playing with her dog Hugo, and most recently, helping to run a COVID-19 task force for the entire state of Maryland, focusing on a COVID-19 vaccination rollout. Ladies and gentlemen, please welcome to Ventura, Dr. Monica Schock-Spana.
Thank you, Dr. Hornstein, and thank you, Dr. Birnbaumer, for that spectacular kickoff with an introduction to vaccines. It is amazing to go back in history and understand the experiences of people and communities before the public health intervention that is vaccines became available. And so what I want to talk about, and as Dr. Hornstein mentioned, I'm actually a cultural anthropologist. So I'm not a vaccinologist, I'm not a virologist or a clinician. I'm focused more on the people side or the human factors. And Dr. Birnbaumer did a spectacular job of showing the impacts of having vaccines and the type of experiences during outbreaks that people had to live with, such as with polio. Um, and, and so we realize and understand the public health value of vaccination. And so what's important, and we've seen this with the investments of the federal government in what has been called Operation Warp Speed, which is the US initiative to research, develop, produce, and distribute COVID-19 vaccines, a major investment in new vaccine technology that we will hopefully be taking benefit of very, very soon. And while we should notice all of the great news that's coming out about vaccines, from a clinical perspective, it's not enough for a vaccine to be clinically effective. It also has to be socially acceptable. So there's a human component to it. There's both the technology and there's also the social side to this. So that's what I'm going to talk about today. And we'll go to the next slide, please. And the next slide. So I was asked to talk about the question of why do people not trust vaccines, for instance. You know, they could be clinically spectacular for us and really protect public health, but why might there be some reluctance to get vaccinated? Next slide, please. So I'm going to touch on the topic of what's called vaccine hesitancy. And I'm going to come to that topic by way of COVID-19 and COVID-19 related vaccines. There's been a lot of polling that suggests that not everybody is going to eagerly rush to the front of the line to get vaccinated against COVID-19. So I'm going to talk about that. Here we have a potential solution rolling out, and yet people may be reluctant to take advantage of it. So we're going to talk about vaccine hesitancy by starting there. I want to also talk about how researchers have approached this issue of reluctance or hesitancy towards vaccines, and talk about the range of beliefs, attitudes, and behaviors, because vaccine hesitancy just is not just a singular type of phenomenon. It manifests itself in very different ways. It's driven by a lot of things in people's environments. So we'll talk a little bit about that. And major reasons or influences upon vaccine hesitancy. And I'll give you a very detailed model that actually shows just how complex people's decision-making is around whether they're going to be vaccinated or not. And then we'll close out with a few ideas about, okay, if people are reluctant and we attend to that reluctance, how might we help people come around to a point in their decision-making that they may be more open to being vaccinated? So next slide, please. So I talked earlier about the fact that we're facing something of a dilemma right now. We have a pandemic where there are too many cases, hospitalizations, and deaths. We've had economic reverberations. We're all living, I mean, this Zoom experience is manifesting it, of having to be physically distant from one another. And to live with the stress of all of that. And here we have some very promising vaccines, but a lot of the national polls in the United States are indicating that there is a significant number of folks who are reluctant or expressing vaccine hesitancy at this time about future uptake of these vaccines. So here we have a solution potentially to a very stressful and traumatic pandemic, and yet people may not take advantage of it. So let's talk about that. Next slide. And I mentioned, yes, thank you. I just want to share a little bit of some reasons that have been picked up in national polling about people's reluctance around future COVID-19 vaccines. So this data is taken from a national poll that was at sort of early mid-September. And at about that time, about half Americans, only half were saying that, yes, they were intending to take the vaccine. But the other half were saying, you know, I'm reluctant to take the vaccine. So what were the reasons that they were giving? A considerable amount of the people who said, no, I don't think I'm going to. 3/4 of those people said that the major reason was concern over side effects. Okay. Another large majority was that they wanted to wait and see. They are desiring to know more about how well it's really going to work. So until they see that, get more data points on how well it's working, they're not planning to get a coronavirus vaccine. And others commented upon that they may not need it, and maybe cost was going to be an issue. But it was side effects and also the desire to wait and see just how things were going to pan out. Next slide, please. I think what's been very concerning from a public health standpoint is in May, about 3/4 or just under 3/4 of Americans said in May, right? This is after sort of major shock of that initial phase of the pandemic. About 3/4 were very open to taking a vaccine. And yet there was this dramatic drop so that we dropped from 3/4 of Americans saying that they would be open to taking a vaccine in May to just about half. And there were nearly about 50% said they definitely wouldn't or probably wouldn't get a vaccine. So, and it's not as if we're all saying yes or no in similar fashion. Actually, some of the most hard-hit communities in the United States are among those most hesitant to be vaccinated against COVID-19. And that's a real dilemma. So if you look at the polling, Black adults in particular are much less likely to say they would get a vaccine than other Americans. And so we're looking at just about 1/3 of Black adults saying that they would definitely or probably get a COVID-19 vaccine. And if we're following the news, we know that local Black communities are suffering very harsh conditions as a result of COVID-19. So there's a disconnect here when we have a community problem and a potential solution, and still there's reluctance. So next slide, please. So, if there are people who may hesitate to take a COVID-19 vaccine, if they're not worried, why should the rest of us care about that, right? Isn't that just a personal choice? And yes, vaccination does protect individuals, but when you step back, you also can understand, and Dr. Birnbaumer's lecture was very helpful here, that there's issues of what is called community immunity. And the spread of a contagious disease can be controlled after a large enough portion of the population becomes immune. And so what that does is help interrupt the transmission, in this case of the coronavirus. But for those fewer individuals who just cannot get vaccinated for whatever reason, if they're immunocompromised, for example, if the rest of us around them are vaccinated, we're sort of a barrier protecting them against the virus. And that's why we should care about the levels of reluctance, both for the individuals who could benefit from vaccination, but also because collectively we all benefit. The next slide, please. And I don't want all of you to walk away and say, oh my goodness, what is all this decline in terms of the Americans' willingness to take a vaccine? Because something happened. In fact, these reports just came out in the news a couple of days ago about a national poll, and there's actually willingness to take a COVID-19 vaccine is starting to go up. And this is going up even before the good news about the several vaccines. And I'm sure Dr. Birnbaumer is going to talk a little bit more about the specific vaccines that are coming out there. So we're starting to see an uptick. So I don't want people to walk away discouraged because things are actually changing. It's a very dynamic field. So let's talk a little bit about, next slide, what is vaccine hesitancy? And a group that was convened by the World Health Organization calls it, and this is the formal definition, so stick with me, folks. It's the delay in acceptance or refusal of vaccination despite the availability of vaccination services. They note that it's complex and context specific, and it varies across time, place, and vaccines. So you'll notice this sort of cartoonish syringe. And so people's decision-making around vaccines is not binary. It's not a yes or a no. There's a lot of gray when people are making decisions. So on the refuse all vaccines, that's actually a very small minority of the population. The vast majority of the population accepts all vaccines quite with a lot of energy, or does it not so energetically, but they do it. And that's where the majority of the behavior is. And in the middle, there are these sort of gray areas. They'll say no, but they're not quite sure. They're sort of pushed or pulled. They're in several directions, and they land on the no. But they could be, under certain circumstances, they could alter their decision. Some may say, I'm good with these vaccines for my child, but I really want to hold off on the others. And so there's a selectivity or a delay in the timing of vaccines. So that whole range of behaviors in the middle is the hesitancy. Next slide, please. So there was an advisory group that was convened by the World Health Organization to try and crack the nut of vaccine hesitancy. What is keeping people from getting vaccinated? And just last year, the World Health Organization called out vaccine hesitancy as one of the 10 threats to global health. They are concerned about the rising rates of reluctance, not in relation to COVID-19 specifically, but across the board. There's worrisome indications there. And so this is what's called the 3C model. What are those factors or influences that seem to be leading to that influence vaccine acceptance? So there's the confidence. The first C is confidence. And it's that element of trust. And it's trust in a lot of things. It's trust in the effectiveness and safety of the actual vaccine itself, the technology. There's trust in the people who are administering it and the facilities that are delivering it, so those larger delivery systems. And then also the motives, the perceived motives of policymakers who say, you know, this should be our approach to the use of this particular vaccine. So confidence makes a difference. Another C is complacency. And Dr. Birnbaumer's lecture was very helpful here, because we don't have the types of headstones today that there used to be for our ancestors. And so vaccines are victims of their own success. So there's a level of complacency because we're not surrounded right now in the United States from diphtheria. While we do have periodic outbreaks, sadly, of measles, we're not surrounded. All parents aren't worried all the time about whether their child is going to become infected with measles or not. So we've become somewhat complacent because the diseases, vaccine preventable diseases, just are not part of our reality. The pandemic is changing that, of course. And then there's the convenience factor. Just how easy is it to get vaccinated? Are vaccines available, affordable, easy to access, and delivered in a comfortable environment? Next slide, please. Don't worry if your eyesight, mine's pretty bad, can't discern this model. But basically, the folks who research vaccine hesitancy, in addition to sort of calling out the 3C model, have tried to document all the things that are influencing people's willingness to take a vaccine. And so next slide, please. So there's sort of these three big chunks. The first is contextual influences. So it's cultural ideas, it's trust in government, it's how we communicate with one another. And right now, social media is playing a major role. So that larger environment makes a difference and has an influence on people's decision-making, what religion they come from, you know, what type of political views on the world do they have. And so here, broader cultural shifts, like what Dr. Hornstein pointed out, is the crisis of trust in institutions, and also what others have called the crisis of truth, where there's a decline in the influence of medical authority and an increasing influence in non-authoritative sources around vaccines. So those are some, you know, the media environment, the cultural environment, people's histories, and the like. Next slide, please. Now, there's issues of individual and social influences. What are people doing around us? How have we grown up in terms of our relationship to vaccines? Do we belong to a community where we believe that more natural interventions are better for our health? Do we believe that we should follow a schedule that's been determined by a distant set of experts? So there's ideas about worldviews, identities, social values that also influence whether or not people will be willing to be vaccinated. If everyone around you who you trust promotes vaccination, you are going to be influenced by that normative behavior around you. So I put up this is a great shot of a 3-generation family taking part in vaccination. And so that is a family that has embraced vaccinations across many generations. So next slide, please. And then another influence is vaccine and vaccination specific issues. So it really does matter about the technology. It does matter about the risk benefit profile of the particular vaccine, costs, scheduled? Do you need one dose? Do you need 2 dose? All of that. How is it administered? Is it a nasal? Is it a nasal version of the influenza vaccine, or is it an injection? And people have preferences. I'm going to just call out shingles. Shingles, sadly, there have been shortages, which make it sometimes inconvenient to get that vaccine. There are 2 doses. Sometimes people forget unless they're reminded to have the second dose. And it can be a little reactive. You may feel a little fluey for a day afterwards, and that's perfectly normal. That means it's working. Your body's developing the type of reaction that it needs. But all those aspects about the shingles vaccine are going to influence people's ability and willingness to take it. So I'm going to stop there because we're going to shift. I think Dr. Hornstein's now going to shift us to issues of how do we take into consideration things going on relative to COVID-19. And I'll turn this over to you, Dr. Hornstein.
Thank you so much, Monica. That was excellent. We're now going to start the question and answer period. And with the help of you, the audience, I'd like to ask you to jot down any questions in the Zoom chat room, and I'll try to get to as many as I can. So let's get right to it. Our first question, mostly directed to Dr. Birnbaumer. Could you please give us a brief update on the status of all the COVID-19 vaccines? And could you please do that in, 5
Oh yeah, not a problem. So I'm actually going to take over for a little while, and I'm going to run through some concepts that I think are super important to understand before we even get into the COVID vaccine itself. And we already had a little referral to what this idea is of herd immunity, but I think that the term is used more loosely than it needs to be. I think we need to be a little more specific. So let's talk about what herd immunity is. So this idea that we have enough people that have immunity where an infection can no longer sort of live anymore, get past other people, is the idea of herd immunity. So for instance, let's take this top guy, this little red guy on the top of this slide, on the top left. And he has a new virus that nobody's ever seen before. It's called a novel virus, like COVID. And nobody has any resistance to it at all. Nobody has any immunity at all. And so that thing runs like wildfire through a community. Now, what our goal is down at the bottom of that slide. The little red guy who's infected in the middle is mainly surrounded by a bunch of green people. They're the people who are immune, to the point where he can cough on somebody and they don't get infected because there's a lot of people who are immune. And the people that Dr. Shaxbana was referring to, who maybe not be able to get things like vaccines, these poor people sitting out here, these little blue guys out here who may never be able to get the vaccine, we're protecting them because there's enough of us that are resistant that that little red guy in the middle can't get the infection to that person who's still at risk. The middle here is where it's the shifting around. We're getting more immunity out there, and our goal is to have as much immunity as possible, as much people who have either antibody they got or resistance immunity that they got from either being infected or getting a vaccine, enough of that conglomerate that vaccine, that virus has nowhere to go. That infection has nowhere to go. There's just no place for it to infect anymore. That's our goal. So herd immunity isn't just, it's kind of getting referred to as you can only have herd immunity if you get whatever the illness is and develop an immunity that way. It isn't. It's a conglomerate of people who may have gotten the real infection and people who got a vaccine of some sort. So to become immune, to that conglomerate of herd immunity, and for most infections, it needs to be between 60 and 80% of the population needs to be immune for this to be able to be stopped, for it not to keep running rampant like this, to keep things in check. So to become immune, to become part of that group of herd immunity, we can either become immune by getting the infection itself, that's one way, or we can become immune by getting some sort of thing like a vaccine where our body gets immune without having to get sick. Now, one of the things that I'm hearing a lot of out there is that it is better, your immunity is better if you get the actual infection. And this is broadly used for lots of infections that are out there. And there's a bit of a yes and a no to that answer. So it turns out that if you get, so say you come down with COVID and you're sick and you're feverish and you're coughing and you're having trouble breathing and you are sick. Well, we know for sure you have that virus. We got your test positive, you have that virus, and you're going to respond. So the thing about natural immunity is that we know you had it, and we know you got over it, and your body got antibodies to it. Your body has now immunity. When we give somebody a shot, or a nasal spray or an oral drop, we give somebody a vaccine, the point is not to get sick, right? That's kind of the point. But the vaccine efficacy may not be as much as if you got sick. So for instance, as an example, these new coronavirus vaccines that are out, they're touting at this point 95% efficacy. That means that 5% don't develop a robust response of immunity, but 95% do. And that's without anybody getting sick. So you're not paying a lot of a price to do that. That's kind of nice. So the thing here is one way, are we better off just letting everybody get sick with COVID, let that run rampant, and let that way people get immune? Or are we better off locking everybody up and getting vaccines only, or some sort of blend of the two? So let's think about this, because it depends. So let's start with just an equal playing field here. And on one side is if you get the infection, everybody recovers and has no chronic problems. That's the good thing. Or on the other side, let's say whatever we're infecting with makes everybody sick, or people die. A lot of people die. So that's the ends of the spectrum of what can happen if you get sick. And our way to get you immune is either to let you get vaccinated. So we do it by giving you something that your body responds to, or we just let you get sick. So let me tell you, it makes a difference how sick you get as far as whether natural immunity is the way to go or not. Let's do this one. So let's say we have an illness where most people will recover and have no chronic problems at all. So they do great. Virtually nobody dies. Virtually nobody has any chronic illness. Everybody does pretty well. So the example of this is chickenpox. So when I was a kid, we had chickenpox parties. Whatever kid in the neighborhood got chickenpox, we all had a big old party. All the kids got exposed because no kid ever really died of chickenpox. You just wanted to get over it and get past it. Well, we also would prefer you don't have your family stay home for 10 days while you're getting over the chickenpox and not work and you don't go to school, et cetera. We have a vaccine now, but this one you could make an argument to say, who says we don't need a vaccine for this? People don't get that sick. It doesn't have any really downside to getting sick with chickenpox. Let's do that. So that's one extreme. But let's take the other extreme. Let's say whatever this illness is, this virus is, really kills people, or really makes them chronically ill. And not a lot of people recover and do fine. The great example for this is Ebola. So Ebola has an 80 to 90% mortality rate. There's no way we're having Ebola parties. Nobody's going to come on over and get immune from Ebola, right? People who survive Ebola are immune, but I'll tell you, the price paid is too high. So this is where natural illness is not the way to conquer this, to get herd immunity. We really would like a vaccine for Ebola. That was what we would like. And then where does COVID fall in this? So in the spectrum of people getting sick and dying and people getting over it, we know a couple of things about COVID. We know most people will not die of this. We know most people will recover. And as far as we know, there doesn't seem to be a ton of chronic illness, but there is some. So this chronic illness thing, there seem to be some people who have that. And we know that the death rate is not insubstantial. It is probably of diagnosed cases of COVID, well, right now, of diagnosed cases of COVID, the death rate is about 2%, between 1.5% and 2%. That's not insignificant. And when it comes to a new infection that is running rampant through a population, one more thing we have to factor in here as far as natural illness versus vaccine is hospitalization. How many people who get that infection need to use medical services? So for instance, chickenpox, you go through it at home. But COVID, it turns out between 15 and 20% of diagnosed cases end up in the hospital. That's a lot of people. So what we're doing here is we have to factor in what's happening to our healthcare resources as well. So to go back to this idea of vaccine hesitancy and what things get factored in, as a society, we also have to decide, is it worth filling up our hospitals so that if you happen to have a heart attack today, but the hospital is full of COVID patients and you can't get cared for, is that something that's important to think about too? So those are the things that we factor in when we think about vaccines. And this is why herd immunity is this combination of vaccine immunity, and some people have natural, quote, natural, I got sick immunity. The combination of that being a hole that's enough to prevent the infection from running through a population, kind of settle it down, shut it down. And by the way, they did that with SARS. So the first SARS burned itself out because they had so few people, they had it all contained in an area. It only infected so many people. It didn't get out. And so it basically burned itself out. That's why that had a 30% mortality rate. That was much scarier. It burned itself out. We never let it get out into the general public. We burned it out in time. We basically had it all controlled. Here we don't. So now we have to figure out this sort of immunity deal. So the vaccine is an issue. The vaccine is important. And the way a vaccine works is most of the time what we do is we take a little bit of the vaccine. You either take the vaccine itself and kind of knock it out a little bit so it's not super infectious, or we actually completely wipe it out and give you bits and particles of that. We put it into you, it's part of this germ. Your body says no can do. It makes antibodies and other kinds of immune responses. And so when you then eventually get exposed to that infectious organism, you don't get sick. You're immune. That's how this thing works. It's pretty great. We have a gajillion vaccines that we've developed out here. This is not even the complete list of the vaccines we have. And what the question now for us with COVID out there is, do we have a COVID vaccine? How good is it and where do we stand? So let's talk about this. People have a lot of questions about this COVID vaccine. How did it happen? How did it be so fast? Blah, blah, blah. Just know that every vaccine that gets approved goes through certain things. So one is it gets tested in animals first. And if it kills a bunch of animals, they're not going to take it any further. Or if it doesn't cause any response at all, they're not going to take it any further. So it had to get through animals first. Then it has to go through just a few people. They give it to healthy people and they look at what happens. Does it make those healthy people sick? Does it cause any antibody response? What kind of dose would we need to get an antibody response? They do that in a tiny group of people to get some pretty important information to then decide, all right, we're going to take it to a bigger group. We're going to take it to a couple hundred volunteers that are healthy. And we're going to see what are the short-term side effects here in the first couple weeks to couple months of this thing. And do the immune responses really work? Does this work? And if that's the case, we go to phase 3. So phase 3 is what we've been hearing about in the news this week. You end up to 10,000s, and actually in phase 3 of the coronavirus vaccines, we're up to tens of thousands of volunteers. And now we're looking at things like, is this effective? So if you get the vaccine, not do you just produce antibodies, but if you happen to now get exposed to COVID, are you protected? Does it keep you from getting sick? That's what the phase 3 is for. And we look into side effects. What are the common side effects, not just of the vaccine, like locally from the shot itself, but is there anything that kind of lingers? Is there anything else that's going on here? And we have now some information. So what came out in this last week and a half is the 2 vaccines that are out there. So what's important to know is it's still pretty skimpy data, but incredibly encouraging. So we have a total of 70,000 people who've gotten this vaccine. And remember, there's a placebo group. There's a group that didn't get anything. They got a shot that wasn't vaccine. And then there's the group that got the vaccine. And it's half and half of these. So it's half of these numbers. What they found is that, the efficacy of 95%, these numbers that they came up with, that 95% of people are protected, meaning they get exposed to the virus, but they don't get sick, come from things like this. They found that the group that got the vaccine in the Pfizer study, there were 8 people who got exposed to coronavirus, who got coronavirus, only 1 was severe, and 162 people in the placebo group. 9 of those were severe. And it was a similar idea when it came to the Moderna vaccine. 5 people who got the vaccine ended up picking up coronavirus, but didn't get sick. There was no severe cases in that one. And 90 people in the placebo group. I got a shot, but it wasn't vaccine. 90 people, 11 of whom got severe with that. And the side effects so far are relatively mild. People are getting fever. They're getting aches and pains. They're getting basically what's like a mild, it's sort of like you heard about with if you've gotten your shingles vaccine, I've gotten my shingles vaccines, both of them. And both times I got a fever and both times it kind of laid me out for a day. That was the side effect that I knew could happen. So we're having side effects that can happen with this that we're aware of. And the dosing schedule for this one, it goes like shingles. It's a 2-dose deal. It's going to take 2 doses. One's 3 weeks apart, one's 4 weeks apart, but it's going to take 2 doses. So this is what we have so far. It is incredibly promising. I have to tell you, it is remarkably promising. And I'm a big skeptic and a big naysayer when it comes to anything new medical, because I'm a big do no harm kind of person, but this is really promising stuff. So where do we stand right now? We are poised on FDA approval for at least one of these 2 vaccines, literally poised on FDA approval. And then once it's approved, what happens? So there is a rollout plan that actually hasn't been shared with the whole world yet, but there's a rollout plan that's general gist we're aware of, where healthcare workers, social workers, frontline workers like paramedics, et cetera, will be the first group to get this because they're the highest risk of getting sick. But then the next rollout group is going to be people at high risk and the elderly. And this may go to nursing homes because we know it's devastated nursing homes. So it's going to focus on that population. And then as far as for everybody else out there, we're going to need more doses of this thing to actually get it out to everybody. But this is the rollout idea of where they want to take this thing. So this is sort of the general plan of what we're going to do. Now, there are things we don't know yet, and I will just be flat out honest about this. There are things we just aren't sure about yet. We're not sure about long-term safety issues. But I have to tell you, on all the vaccine studies to date, on all the other kinds of vaccines out there, if a bad thing happens from a vaccine, it tends to happen within the first 2 to 3 months after you receive the dose. It's not a long-term deal. Rarely does that happen. There are cases remotely, but it is really, really not common. So the reason they use this 2-month safety window, 2 to 3 month safety window before they say it's safe, is that's when most of it happens. And you already saw in the news where some of these trials got stopped when there was a case that could have been a bad thing from the vaccine that turned out not to be. And it wasn't from these studies, it was from a few of the other kinds. By the way, just so you know, there are 10 other vaccine types that are in phase 3 trials right now. That one where it's out in tens of thousands of people to see where it goes. There are 10 other, then there are 100 types of vaccines that are being tested out there. So this is just the first 2 of a bunch that may come down the pike. So for these 2 right now, we're not sure of the safety issues, but they're probably fine. We're not sure how long immunity is going to last, but I have to tell you, research this week was very encouraging in this regard. Research as far as immunity to the coronavirus itself, but there's 2 types, T cell and B cell immunity, and it looked like that the one that's like the memory one, the one that remembers, that one is very robust, and it stayed very robust for the people who survived SARS-1. So that's exciting. That's exciting, and it gives some real encouragement that this may be lasting immunity. How long, we're not sure yet, but it may be lasting much more than we thought it might be. Can people who are vaccinated still carry the virus? And that is a question we don't know yet. We don't know yet. You may not be able to get sick from the virus, but can you carry it in your nose and then give it to somebody else? That we don't know. So right now, even though there's a vaccine on the horizon, it is pretty darn encouraging. It means that we're still stuck with those masks for a while. So I strongly suggest that you go out and buy masks for the holidays and buy masks for New Year's that say Happy 2021 and masks for Valentine's Day and Easter and St. Patrick's Day, because we're going to be wearing these for a while until we're sure that if you're immune, you can't still harbor it and give it to somebody else, even though you're not getting sick. So those are still going to be around for a while. So that's the long answer to where are we now on COVID, but I hope it kind of helped allay some fear, give you some information, so you can have some idea of what decision you might make when it comes toward you.
Diane, that was superb. Thank you so much. Second question, compared to traditional vaccine development, the COVID-19 vaccines, all of them, have been developed at warp speed. And maybe warp speed, however, isn't so good when it comes to approving drugs for short and long-term safety. So this question is more for Dr. Shak-Spana. What should the FDA, the Food and Drug Administration, the CDC, Center for Disease Control and Prevention, and even the drug companies do to public trust that these vaccines will be safe, effective, and useful for the majority of the American public?
Thank you, Dr. Birnbaumer. That was very, very helpful. I think it's important. I know our central idea for today's or tonight's forum is trust. When it comes to vaccines, I think we need to think both in terms of people's acceptance of the vaccine and people's access to. Because whether or not people get vaccinated isn't just an issue of the confidence. We talked earlier about the confidence in the technology, the confidence in the people who are administering the vaccine, the confidence in the institutions that produce and review and regulate. Confidence is clear, but I also want us to focus on issues of convenience, because that's also going to be important. Right now, there are groups in the United States who may want to be vaccinated, but for social and economic reasons face barriers to getting vaccinated, and that should also be of a concern to us. What can the federal or U.S. government do now, to respond to Dr. Hornstein? Right now, we need to have a coordinated, evidence-based communication strategy and elements around COVID-19 vaccines. And some elements of that communication strategy have to include: one, setting realistic public expectations about the entire vaccination enterprise. And Dr. Birnbaumer talked about the staging, that prioritization of certain groups, because it's not as if enough doses for 300 million Americans are going to be available all at once, okay? It's going to take some time to produce a large volume of doses for Americans. And so we need to be prepared for that staging process. Okay, so that's a public expectation setting. There's been such a desire to get a vaccine as quickly as we can and feel both the physical health, the mental health, and the economic relief that can come as a result of it. But it's going to take some time to get everybody vaccinated. So we need to set some realistic expectations. Another realistic expectation is, and I think in your data, Dr. Birnbaumer, you talked about the people's sort of the typical side effects of vaccination. People need to, again, people's expectations need to be set about the fact that a sore arm is an okay experience when it comes to getting vaccinated. And so people need to be readied for even the smallest, sense that they have been hurt in some way. People need to know what is typical in terms of a body's reaction to the introduction of a vaccine. So there's some expectation setting there. With a second thing, apart from public expectation for that communication strategy, is this is a very dynamic field right now. There are, yes, these, the Moderna and the Pfizer vaccines, but as Dr. Birnbaumer said, there are many still in the pipeline. And so we have multiple vaccines, the likelihood of 2 doses needed. And so there are some complexities to the delivery of the vaccine. So people need to be ready for the fact that we're not just talking about one vaccine, one dose, one size fits all. There's going to be a level of complexity. So we need to be able to communicate that. And again, setting some expectations. Also, with regard to that communication strategy, there's a tendency historically to try and bring people around to vaccination strictly by laying on fact after fact after fact after fact. And yes, facts and good information, solid information about efficacy and safety of a vaccine are absolutely central. But vaccination is a more whole person experience, right? It isn't just about your immune system. It's also about all the things, all the cascading things that can come from you being vaccinated, your family being vaccinated, and the larger community being vaccinated. So apart from sort of the immunological benefits, I think the communication strategy really needs to also focus on the civic benefits, which is a vaccinated community can get back to work more quickly, and income is more predictable. A vaccinated community can start worshiping together again. They can go to their mosque, their synagogue, their church, and be shoulder to shoulder with the people in their worshiping community. And so there are those social benefits that I think we also have to communicate very strongly about. And so the public health and medical authorities should be partnering with religious leaders, community leaders, social influencers on social media to talk about all the cascading benefits of vaccination against COVID-19. So, and then lastly, that communication strategy needs to be consistent. I mentioned earlier about coordination. People are able to make more informed decisions when they're getting consistent information about the benefit of a good or a service. In this case, it's a vaccine. And so when you have competing messages and they're all coming at you, it is a great deal of work, cognitive work, and also emotional work to try and piece together what it is you are supposed to do. And so it will be very important for physicians and nurses and health officials and mayors and governors and elected officials of state, local, and federal, that we're all singing off the same song sheet. It will just improve people's ability to make good decisions. So I would say that communication is going to be central, setting expectations, letting people know that there's a lot of dynamism right now, and they will be kept apprised. And we need to talk about vaccination in civic terms, not just immunological terms, because the pandemic is affecting all of our lives. Vaccination too can affect all of our lives in a very positive way. So I'll turn it back over to you, Dr. Hornstein.
Thank you so much. That was an excellent answer. Along those lines, as far as transparency, one of our audience asked, will the COVID-19 vaccine cost money? And will that be covered by insurance?
I have seen statements to the effect that for people who want the vaccine, it will be available to them at no cost. But going back to the convenience issue, it isn't just the issue of the cost of vaccine. There are also opportunity costs. So let's talk again about the access issues. It'll be important to make vaccines available in convenient locations. So workplaces, once the vaccines become broadly available, workplaces can be enrolled. That way people don't need to take off from work and lose income in order to be vaccinated. And so we don't want people having to make a choice between pulling down a paycheck and going to get vaccinated. So there are those opportunity costs. We want them to be provided in locations that are readily accessible by transportation. If I have to get on a bus to go to a vaccination clinic that's 90 minutes across town, and I have to arrange for childcare, that's an opportunity cost. So apart from the actual price tag of the vaccine, we have to create a distribution system that doesn't create other lost opportunities for people, much as I just talked about. time and money.
Excellent. This question, I think, is more for Dr. Birnbaumer, but again, please feel free to chime in. Have there been reinfections with COVID-19 viruses? In other words, have people gotten the virus and then gotten it again? And if so, should those people be getting the vaccine? And will that happen to patients who get the vaccine?
So the answer is yes, but it's not that simple. So a couple of things. There have been documented reinfections, and let me tell you how they found the first one so you understand how it happened. A young man got COVID in March, had a virus test with what's called genome sequencing. They actually were able to say exactly which version of the COVID he had. He had antibodies that developed, so he had an antibody response, and he no longer was sick. So he was basically over that episode. Then several months later, actually this was reported in August, he was traveling, and as part of the requirements for travel, he had to be retested as part of the travel. He was fine, but he had to get retested, and he tested positive. And they looked at which coronavirus he had, and just these little tiny changes that can happen in the virus. It was a different virus. It wasn't the old one suddenly back again. It was a different virus. It was a different coronavirus. Coronavirus still, but just a little different version of it. So they proved that he was a reinfection. Now, the good news is he was asymptomatic. His antibodies did what we want antibodies to do. They were able to test it in him, but he didn't get sick. There are now a handful, and it's literally only a handful of reported cases so far of reinfection. Only one death from reinfection, and that was in Europe, an quite elderly woman who already had a lot of medical conditions, and it may not have been related to the COVID at all. It may have just been that she was very sick already and set to die. So the answer is, can you get reinfected? Probably yes. And what happened in the reinfection is exactly what we're looking for here. The antibody that person had, they didn't get sick when they had the virus again. It because the virus isn't going to go away. It's just going to be out there. So it did exactly what we're kind of hoping will happen. So it's sort of a good news, bad news deal. And it's going to be hard to know how many people are reinfected if they're not symptomatic. We're not testing for that. We don't want to test for that. So I think the news is pretty good in that regard. And that individual case, I think, is a very illustrative of why.
So I'd like to ask a follow-up to that. Since about 50% of people who get COVID-19 actually have no symptoms and don't even know they have it, Justin Turner being an example on the Dodgers, had the infection, was infectious, didn't know. How will he know if you don't have symptoms that you should or should not get the vaccine?
That's a good question. So I think that's part of the rollout issues that they're dealing with. So a couple of things, like say you know you had the infection. Let's just be more extreme on this. You know you had the infection, and you may even know you have antibodies. They have not tested the vaccine in people who had known COVID. Because kind of that would sort of taint the study. You want the study to be kind of pure. You want it to be the beginning studies, you want it to be as pure as possible. So make it as clean as possible. So they didn't test it in people who already had COVID. We don't know how long that natural immunity will last. It's looking pretty encouraging, but we don't know yet. So right now, I cannot answer. We're so preliminary and all this stuff. I can't answer for sure whether if you've known COVID, should get the vaccine again. And they haven't tested that to know. If you don't know you've had COVID, I think the reality is they're not going to test antibodies in everybody. I think they're just going to offer this out as it gets rolled out. But those nuances, again, I'm not purview to. I don't have an Operation Warp Speed sort of little button to click here to know what the rollout is going to be as far as those individuals. But I understand some of the conundrum and the questions people have about that.
Another individual from our audience said, I'm concerned about the addition of mercury, aluminum, and other toxic substances in vaccines. Although the amounts may be small, any amount she fears is toxic. Do you know if mercury, aluminum, or other types of toxic substances will be in the coronavirus vaccine?
I will beg that I don't know. I'm not sure about that. I know that I'm not sure about it. My guess would be no, only because this thing is very fragile. You've all heard about how cold this thing has to be. And you think about this vaccine as an M&M. So it has this like lipid coating on it, but inside is this RNA that's like the thing that's going to go tell your body what to do. And that you've got this coating on it that's this fat kind of stuff. And it has to be kind of frozen to keep it protected. It's one of the reasons it has to, if it gets too warm, that fatty outside melts and the whole thing kind of just falls apart. This thing just, it becomes ineffective. It becomes something that just isn't put together anymore. So my guess would be no, but I will tell you flat out, I cannot answer that honestly, because I don't know exactly what's in the vaccine itself. Most of those are preservative things that for the stuff that sits on a shelf in a room. I suspect this is not like that, but I'm just guessing here.
Thank you. Another questioner asked, and I think either of you, but maybe Monica can take a stab at this one. I'm also concerned that anytime someone posts on the internet something that's negative about vaccines, it is removed and ridiculed, and people are referred to always as anti-vaxxers when they just might have legitimate concerns for safety. How do you address people who have legitimate concerns to not be stigmatized as being anti-vaxxer or somebody that's not really concerned about the health of communities?
Yeah, the shaming and blaming during the pandemic benefits no one. It doesn't benefit the person who's trying to shame someone else, and it certainly doesn't benefit the person who's being singled out. People are looking for good, solid information such that they can make choices for themselves and for their loved ones and for their community. And people have different types of information they're looking in order to make those decisions. They rely on different sources. So I think, like I was trying to do with vaccine hesitancy, there's a lot of gray when it comes to people's decisions about whether to be vaccinated or not. And we have to give a little grace to everyone during this time. These are new vaccines. They're exciting. At the same time that they are cutting edge, they're also new. And they haven't been, used like flu vaccines have been used in millions and millions and millions and millions of people, and then in millions and millions and millions and more people. So we have more data points. So we need to allow some space here for people to gather the type of information that they need. And, as far hearkening back to communication is, we in public health need to do a better job of listening to people and not writing off reluctance as one type of behavior. There are many reasons why people are hesitant. And so we need to do a better job of listening to people's concerns and speaking in ways that are meaningful and that resonate with them personally, and to dismiss people's concerns outright, and painting someone as an anti-vaxxer simply because they have concerns, they want questions answered, is not useful at this time. And Dr. Birnbaumer, I'm sure, has some full thoughts to share on this question.
Oh, you covered that beautifully. I think that if I were queen, I would eliminate any comments and any retweeting, and I actually would love to eliminate social media completely. But if nothing else, I would like to eliminate anyone being able to comment on anything and forward anything, retweet anything. I think people need to think for themselves and quit jumping on quick bandwagons and quick terms and judgment. And we all need to take a step back and think and listen. And so this social media maelstrom that's out there, this terrible rabbit hole people get sucked down into, is very anti-human, right? We don't do that. We talk to each other, we hug each other, we It isn't a normal behavior for us. We would not do that in the real world. Walking around outside, you wouldn't do that. So I think part of this is I'm going to declare like a national day of you don't get to comment and you don't get to retweet at all today. And I think the world would be a better place, and where people just don't troll each other. Just don't do it. You just listen to somebody. It's amazing how often we have the same concerns. We just call it something different. And instead of doing this, we talk to each other.
You know, I wish we had so much more time. I'm sitting here with at least 50 questions that I can answer, that I could ask, and would love to hear the answers. We have time for one more. And along those lines, I'd actually like to ask both of you this question to sort of broaden it slightly. What is being done to vaccinate the rest of the world? And what should be the US role both in vaccinating the rest of the world? This is a pandemic across the entire globe. Everybody is being affected by this. And although certainly we care about it in Ventura and in California and in Texas and in the United States, what is being done to vaccinate the entire world? And what should the US role be in that effort? And in 1 or 2 minutes, please answer.
So you got the answer to that, Dr. Schuxman?
Well, we do need to remember we are part of a global community, and we cannot think strictly in terms of who resides on US soil. We have to, the well-being of all of us on the planet is contingent on vaccination outside of our national borders. So it's going to be important that the US pitches in with the rest of the international community and says, we want to make sure that priority groups in any country are getting access to vaccines. And Dr. Birnbaum,
Yeah, I agree. And I think that the thing is, it's not our responsibility. This is a global responsibility. So it's not like we are going to go do this. This has to be coordinated, and people have to talk to each other, and resources have to kind of get figured out. And so this isn't the US doing it. This is the US being part, because it has to be a global thing. That's the only way to know who needs what where. And I mean, this virus probably came to us in New York from Europe. I mean, we travel. It is a global thing. This is everywhere. So there has to be a coordinated effort. And it isn't, again, just us. We're part of a global community. So our country and our virus, the vaccine development, we're not the only ones doing this. There are people developing vaccines all over the world. So this coordinated effort where everyone gets to benefit is kind of how we're all going to do the best.
Yeah.
Thank you so much. Now, as is our tradition in the Ethics and Society program, we invite each of our guest speakers to have 1 minute to share with us some closing thoughts. Dr. Birnbaumer, let's start with you. It's your soapbox.
Who knew, right? Who knew when we all celebrated New Year's 2020 what this would bring? I have found this head-spinning, really mind-boggling year to be intellectually stimulating, personally terrifying. I've had highs and lows more than in my entire life based on all the things that have to do with this pandemic. What I want you to walk away with today is that there is definite hope on the horizon here. This is not a shrug your shoulders, oh, well, whatever happens, happens. We have a lot of control right now on what happens between now and when everyone is vaccinated. And I'm going to get on a soapbox right now. The biggest control you have right now to protect you and your family is to just have a Zoom Thanksgiving. We are on the cusp of a total disaster in this country. And we're lucky right now in California. We're on the better end of things. And just be safe, because there's a vaccine coming down the pike. Any death right now would be tragic, more so, because there's hope at the end of this thing. So please protect yourselves, protect the people you love, because the cavalry is coming. Fauci said it's coming. It is. So let's just stay as healthy as we can and safe as we can until that's here. And that's sort of my soapbox.
Thank you so much. Dr. Schuxman, please share with us some of your closing thoughts.
I think that, again, that it's on us. Okay, it's on us. The vaccine is coming. And while I'm hopeful, I also want to sort of underscore that there is no singular magic bullet to fix this pandemic. We're going to have our toolkit and use everything that's in our toolkit. And we're going to have to keep using everything that's in our toolkit. So mask wearing is going to be important. Physical distancing, when that is appropriate, needs to be engaged in. We need to be sharing good information with each other. Communication should be in our toolkit. Messages should be in our toolkit. And vaccines need to be in our toolkit. And so there's not a single tool that's going to do it for us. We got to use them all. And so, as I said, it's going to take a while to get everybody who wants and needs a vaccine to get it, because there's over 300 million of us, at least in the United States, and then there's the globe. So we need to persevere with the public health interventions and do risk reduction as much as we can. And we're in it together. I mean, we all have to pitch in. So thank you very much for joining us here tonight. And over to you, Dr. Hornstein.
Ladies and gentlemen, please join me remotely in thanking our two exceptional expert speakers, Dr. Diane Birnbaumer and Dr. Monica Schock-Spana. Thank you so much for attending tonight's program. And on behalf of the entire Community Memorial Health System, we all wish you and your family a happy, healthy, safe, mask-wearing, wash your hands, social distancing Thanksgiving. Happy holidays, everyone. Good night.
Good night.
Good night.